Bismillahirrahmanirrahim. Welcome in this meeting of Egyptian Society of Nephrology and Transplantation CME chapter meetings. I am pleasured to have our dear colleague, Professor Hesham Elghonaimy, Associate Professor of Internal Medicine and Nephrology, Faculty of Medicine, Alexandria University, as a speaker today. Professor Hesham will speak about Scleroderma kidney manifestation. And we were speaking before this meeting started that it is a rare disease that we do not usually find in our usual practice a lot, but it is present disease. We find it from every now and then, and we need these informations regarding this disease. And to collect all of these informations in one lecture to be easily detectable and applicable, and this is our aim today and what I expect from Professor Hesham to do regarding his lecture. Thank you, Dr. Mu'tasim Sayed, lecturer of nephrology in Mansoura Nephrology and Urology Center, Mansoura University, for his being the coordinator of this meeting and for all of his work regarding CME chapter and the SNT educational activity. He is one of the most active, which I really depend now and dependent all through the past periods. I managed this mission, dependent on Mu'tasim as the first one to help me. Thank you, Mu'tasim, for all of your work. And I will leave the floor to Professor Hesham to start his lecture and come to you with the discussion again following the lecture. So please, Professor Hesham, start.
Okay, Assalamu alaikum wa rahmatullah. Thank you, dear Professor Dr. Yasser, for your nice introduction, and thank you, my dear colleague Dr. Mu'tasim, for organizing this meeting. I hope to be a fruitful scientific meeting, and that all of us gain knowledge and benefit from this meeting. Today we will speak about Scleroderma kidney manifestations. As Professor Dr. Yasser mentioned, it is a rare disease, but sometimes rare diseases are underdiagnosed. That's why sometimes the incidence is falsely low than the actual incidence. First, systemic sclerosis is a systemic autoimmune disease characterized by vasculopathy due to dysregulation in the innate and adaptive immunity, leading to collagen deposition and fibrosis in the skin and internal organs. According to the extent of skin involvement, the disease is subdivided into limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis. Diffuse cutaneous systemic sclerosis, of course, has much widespread skin involvement and the fibrosis of both the skin and internal organs. The speed and the extent of progression of kidney disease correlate well with the severity of systemic manifestations and visceral involvement. Renal complications are common, affecting about 50% in systemic sclerosis patients, and 50% we mean symptomatic kidney involvement, but kidney involvement is expected to be affecting about 80% of systemic sclerosis patients, like isolated decline in glomerular filtration rate without having manifestation. So kidney is one of the most affected organs in systemic sclerosis. Renal involvement, of course, if it occurs, it remains an important cause of morbidity and mortality in scleroderma. As regards the epidemiology, the disease is common in South Europe, North America, and Australia. It has a female predominance, female to male ratio about 3 to 1. The peak incidence occurred about the age of 50, but the disease can occur in people of all age groups. The incidence is variable worldwide, but in general, it is considered a low incidence disease. The incidence in USA ranges from 7.2 to 33.9, and in Europe ranges from 13.5 to 44.3 per 100,000 individual yearly. To diagnose systemic sclerosis, we have a proposed criteria from the ACR-EULAR, ACR, the American College of Rheumatology, and EULAR, the European League of Rheumatological Diseases. In 2013, we have a proposed criteria to diagnose systemic sclerosis. We need a score of 9 to diagnose systemic sclerosis. There is one sufficient criterion. If fulfilled, the diagnosis is clear, which is scleroderma of the skin of both hands proximal to the metacarpophalangeal joints of both hands. If this criterion is present, it is only sufficient to diagnose systemic sclerosis. If not sufficient, a collection of manifestations giving the full count of 9 can diagnose systemic sclerosis like sclerodactyly, fingertip injuries in the form of ulcers or digital beating scars, telangiectasia, pulmonary arterial hypertension or interstitial lung disease, Raynaud's phenomenon, or the presence of autoantibodies characteristic to scleroderma like anticentromere, anti-topoisomerase 1, or anti-RNA polymerase 3. The broad classification of scleroderma gives us two main topics. Number one is systemic sclerosis, which is subdivided into diffuse cutaneous systemic sclerosis, limited cutaneous systemic sclerosis, and overlap syndromes. And the second classification is just localized scleroderma without internal organ involvement in the form of morphia or in the face, for example, or linear scleroderma. We have a characteristic subtype from linear scleroderma, which is called the incubed sabr or below of the sword. It affects the frontoparietal region in the form of scar, and sometimes it is characteristically associated with CNS manifestations. Of course, we will focus more on systemic sclerosis, which gives us manifestations affecting the kidney. The first subtype of systemic sclerosis is diffuse cutaneous systemic sclerosis. In this subtype, we have characteristic proximal scleroderma, proximal to the metacarpophalangeal joints, but also it can affect the trunk and the face, and it can give rise also to distal scleroderma. But the most important is that we have proximal scleroderma extending proximal to the metacarpophalangeal joints. It has a rapid progression and wide skin involvement, and the disease characteristically progress rapid following Raynaud's phenomenon. Characteristic large number of visceral involvement. It carries poor prognosis, and the characteristic antibody present in this subtype of systemic sclerosis is anti-scleroderma 70, or the other name of this antibody is anti-topoisomerase 1. Unlike limited cutaneous systemic sclerosis, here the scleroderma mostly affect the distal extremities. It can involve sometimes the face and the neck. It has delayed appearance of visceral involvement. There is prominence of calcinosis in the skin and the telangiectasia. It carries somewhat good prognosis due to poor involvement of viscera. The characteristic autoantibody in this subtype is anticentromere antibody, and there is a subtype of limited cutaneous systemic sclerosis, which is called the CREST syndrome. I think all of us remember this from the undergraduate period. C stands for calcinosis, R stands for Raynaud's phenomenon, E stands for esophageal dysmotility, S sclerodactyly, and T telangiectasia, CREST syndrome. What about overlap syndrome? Overlap syndrome means that the patient is having criteria sufficient to diagnose at least 2 connective tissue diseases. For example, lupus in addition to rheumatoid arthritis or polymyositis. The difference between overlap syndrome and mixed connective tissue disease, if we don't know, mixed connective tissue disease is considered a subtype of overlap syndrome. But in mixed connective tissue, we have certain criteria. These patients are having the criteria of systemic lupus. They are having the criteria of polymyositis. They are having the criteria of scleroderma, in the addition to the presence of specific antibody, which is anti-uridine 1 ribonucleoprotein. So mixed connective tissue disease is a subtype of overlap syndrome. This is example of the autoantibodies which can be encountered in cases of systemic sclerosis. As we said, anti-topoisomerase 1 or anti-scleroderma 70 is more common in the diffuse form, anti-centromere in the limited form, anti-RNA polymerase 3 is a characteristic for the complication of scleroderma, famously known by scleroderma renal crisis. Another important also autoantibody is anti-uridine 1 ribonucleoprotein, which is characteristic for the presence of mixed connective tissue disease. So lots of autoantibodies can be present in cases of systemic sclerosis. Even ANCA antibody, as we will mention, antiphospholipid antibodies, all these can test positive in cases of systemic sclerosis. What is the pathogenesis of systemic sclerosis? It is considered a complex autoimmune disease with interplay between genetic predisposition and the environmental triggers. Environmental factors encountered as silica dust in welders, organic solvents like those workers with benzene and toluene, oral hydrocarbons like vinyl chloride, rapeseed oil and rapeseed oil, contaminated rapeseed oil characteristically in Spain in 1981 led to an outbreak of scleroderma-like illness called at that time toxic oil syndrome. This rapeseed is present mostly in Europe and USA. It is one of the agricultural seed, and the oil delivered from this seed can be used in cooking. Contamination of that oil leads to scleroderma-like illness in 1981, which is called at that time toxic oil syndrome. Bleomycin, one of the anti-neoplastic drugs used in treatment of ovarian cancers and sometimes neck cancers, is blamed to cause scleroderma-like illness. L-tryptophan containing supplements used for treatment of depression, bipolar disorders, obesity, insomnia is blamed also for scleroderma-like illness. And it has another characteristic name, which is eosinophilia myalgia syndrome. And also it led to outbreak in 1980s. Sometimes silicone implant is blamed also for scleroderma-like manifestations. Genetic predisposition in the form of characteristic association with certain HLA alleles like HLA-DRP1, 0407 and 1304. And also there is evidence of autoimmunity, whether in the cell-mediated immunity or humoral immunity, with the characteristic induction of pro-fibrotic and pro-inflammatory cytokines and the presence of autoantibodies and the hypergamma globulinemia. So the pathogenesis is complex with interplay between genetic predisposition, autoimmunity, and environmental factors. That's to say, a susceptible host having genetic predisposition is exposed to triggers which lead to immune activation that ends with fibroblast cell activation, overactivation of fibroblast cells, and endothelial cells activation and damage leads to obliterative vasculopathy and fibrosis of the skin and the internal organs. This is some figures of the characteristic manifestations of the systemic sclerosis, like Raynaud's phenomenon. Of course, all of us know Raynaud's phenomenon. It is a characteristic sequence of triad of digital pallor due to vasospasm, and then cyanosis occurred due to accumulation of deoxygenated blood, and then this is followed by rubor or redness due to reactive hyperemia. Raynaud's phenomenon, of course, is not characteristic only for systemic sclerosis. It can be encountered in many of connective tissue disorders like rheumatoid arthritis and also like systemic lupus. Telangiectasia, which characteristically blanches with pressure, is common in systemic sclerosis, particularly the limited cutaneous form. Skin manifestations passes by through stages. The first stage is the edematous phase, followed by induration phase, and then there is contracture atrophy. Then there is contracture atrophy and the tightness, severe tightness of the skin. And this is also example of digital resorption of the distal phalanges, which can be encountered in severe cases of systemic sclerosis. digital beating scars. Digital beating scars is also one of the most important findings that can aid us in the diagnosis. The old criteria for diagnosis of systemic sclerosis relied on the presence of one major criteria only, as the new one proposed, which is scleroderma proximal to the metacarpophalangeal joints, or the presence of two minor criteria. One of them was digital beating scars by basilar lung pulmonary fibrosis or sclerodactyly. So digital beating scars is one of the characteristic manifestations seen in scleroderma. This is example of calcinosis cutis seen in Crest syndrome. There is calcific deposits in the skin, and of course it can be seen well if we make X-ray on the hands. We can see characteristic calcium deposits as we see with this radio opaque shadows of calcification. What about scleroderma kidney manifestations? We have passed by a general introduction of systemic sclerosis, and now we wanted to focus on kidney affection in scleroderma. All of us, when it comes to our mind, the scleroderma, then we hurry up into the diagnosis of scleroderma renal crisis. This is the most severe affection of the kidney by scleroderma, but we have several forms of kidney affection which can be seen in cases of systemic sclerosis. Scleroderma renal crisis, and astonishing to some of us, not all cases of scleroderma renal crisis are associated with hypertension. 10% of these cases can be normotensive, and this is, of course, is a challenge in the diagnosis. Hypertension, whether isolated or in association with ANCA-associated glomerulitis or scleroderma renal crisis, antiphospholipid syndrome-related nephropathy, isolated proteinuria or isolated decline in GFR, elevated intrarenal vascular resistance. Sometimes we have functional renal impairment due to, for example, cases complicated by pulmonary hypertension and right ventricular hypertrophy and right-sided failure, giving rise to congestion in the kidney due to elevation in the central venous pressure, and this can give rise to pre-renal impairment. Excessive use of nephrotoxic drugs like non-steroidal anti-inflammatory drugs or diuretics, upper GIT bleedings from GIT manifestations. Systemic sclerosis is one of the most diseases of connective tissue, which can give rise to GIT manifestations, starting from the esophagus with GERD, gastritis and delayed gastric emptying, small intestinal bacterial overgrowth, paralytic ileus, pseudo obstruction, chronic diverticulosis. It have lots of GIT manifestations, and these GIT manifestations, of course, can give rise to bleeding, whether occult or frank, which can give rise also to pre-renal impairment. So there are diverse kidney manifestations which can be seen in cases of scleroderma. Number one, scleroderma renal crisis. This is the most feared and serious complication of scleroderma affecting the kidney. It is characterized by acute elevation of serum creatinine that may or may not be accompanied by new onset moderate to severe hypertension. If we look at this definition, number one, as we said, not all cases are associated with hypertension. 10% of the cases can be normotensive. Number two, not all cases are associated with severe hypertension to diagnose scleroderma renal crisis. Even moderate hypertension with acute elevation of serum creatinine should raise our attention that this may be a scleroderma renal crisis in a patient known to have systemic sclerosis. Scleroderma renal crisis is more common in the diffuse cutaneous systemic sclerosis rather than the limited form, and the incidence is characteristically high in the first 4 years after diagnosis of the disease. If 4 to 5 years have passed after diagnosis of the disease, the occurrence of scleroderma renal crisis is less likely. It has an estimated prevalence about 5 to 10% of all patients having systemic sclerosis. There are certain risk factors for developing scleroderma renal crisis. Number one, as we mentioned, the diffuse form of the disease. Number two, high-dose corticosteroids can precipitate scleroderma renal crisis. The presence, as we said, of a characteristic antibody called anti-RNA polymerase 3 antibody. Myocardial involvement, new onset heart failure, arrhythmia, so that's to say severe cardiac manifestations, new onset anemia, early diagnosis of the disease. As we said, the first 4 to 5 years after diagnosis of the disease, the incidence of scleroderma renal crisis is much higher than late in the disease. Rapid progression of skin thickening denoting severe disease, cyclosporin use and contracture at large joints. Of course, two drugs can precipitate scleroderma renal crisis, cyclosporin use and high-dose corticosteroids, and this is a challenge if these patients develop the end-stage renal disease and in need for transplantation. We have a United Kingdom Scleroderma Study Group proposed criteria in 2016 for the diagnosis of scleroderma renal crisis. Number one, hypertension. Hypertension is defined by new onset moderate hypertension of more than 150/85, or just increase in 20 millimeter mercury from the usual basal systolic blood pressure. And this is the clue for the diagnosis of the normotensive type of scleroderma renal crisis. If we know the basal systolic blood pressure of our patient who is following with us regularly, if there is a rise of more than or equal 20 millimeter mercury with acute elevation in renal function, we can suspect in this patient scleroderma renal crisis. Acute kidney failure is defined as increase by 0.3 milligram per deciliter within 48 hours, or increase in creatinine 1.5 times from a stable baseline. Another desirable criteria for diagnosis, the presence of TMA, thrombotic microangiopathy, as a complication of severe hypertension, which can sometimes be encountered in these patients. Hypertensive retinopathy evidence on fundus examination, flash pulmonary edema due to overactivation of RAS system leading to fluid retention, oliguria or anuria, and the characteristic onion skin proliferation seen in the intrarenal arteries and the arterioles in kidney biopsy, with characteristic glomerular shrinkage due to ischemia and the fibrinoid necrosis. So these are desirable criteria that, if present, give us more support for the diagnosis, but they are not essential for diagnosis. With regard to the pathogenesis of scleroderma renal crisis, here there is interplay between the endothelin pathway and the RAS system. There is increase in endothelin level with overexpression of endothelin receptor type B, and there is hyperplasia of the juxtaglomerular apparatus leading to increase in renin, in addition to the presence of anti-endothelial cell antibodies leading to endothelial cell injury with induction of pro-fibrotic and pro-inflammatory cytokines. This leads to obliterative vasculopathy, as we mentioned the findings in renal biopsy in the previous slide, and all this gives rise to severe intrarenal vasoconstriction leading to decline in the GFR, albuminuria, hypertension, and precipitating the scleroderma renal crisis. This is example of the kidney biopsy findings which can be encountered in scleroderma renal crisis, as we see here in figure A. There is intimal thickening in the interlobular arteries. In figure B, there is a characteristic onion skin appearance due to myointimal cell proliferation in addition to intimal thickening. As we see here in figure C, there is severe obliterative vasculopathy, and this red areas is fibrin deposition in the intima and the lumen. Here in figure D, as we see, there is a collapse of the glomerular tuft and wrinkling of the glomerular basement membrane, which is also seen in electron microscopy, in addition to widening of the subendothelial space due to endothelial cell lysis. Diseases to be considered in the differential diagnosis of scleroderma renal crisis. Of course, renal artery stenosis can give us a rise of flash pulmonary edema, like that which is sometimes seen in scleroderma renal crisis. Other causes of thrombotic microangiopathies like TTB and atypical HUS. And by the way, there is case reports of association between TTB and scleroderma renal crisis. Rapidly progressive presenting glomerulonephritis, and in most of the cases, this is associated with positive B ANCA. Toxic nephropathy leading to severe tubular damage and AKI, transplant rejection. All these can be considered in the differential diagnosis of scleroderma renal crisis. Management of scleroderma renal crisis. Of course, it needs a high index of suspicion, as we said, acute elevation in serum creatinine with or without moderate onset or severe hypertension. In these patients, number one, we will triage these patients according to the blood pressure and the presence of severe symptoms. According to the blood pressure, if the blood pressure is less than 180 over 110, these patients can be managed in the ward. The target in the reduction of blood pressure in these patients is 20 millimeter mercury for systolic blood pressure and 10 millimeter mercury for diastolic blood pressure daily, with the target to reach control of blood pressure within 72 hours. The antihypertensive of choice for scleroderma renal crisis by evidence is ACE inhibitor, and the evidence is in support of ACE inhibitor rather than ARBs. The role of ARBs is just if there is intoleration to ACE inhibitor, but there is limited evidence for benefit of ARBs over ACE inhibitor. So the class of choice is ACE inhibitor, not ARBs. We give the patients ACE inhibitor in the form of intermediate acting or short acting. Intermediate acting like ramipril or enalapril, and short acting like captopril. Captopril has the benefit of a very rapid onset of action. Of course, all of us in patients presenting to ER having severe hypertension, we prescribe sublingual captopril. Why? Because captopril starts to work by after 5 to 10 minutes and reaches peak after 30 minutes. So in hemodynamically unstable patients, and I mean by hemodynamically unstable patients, patients having severe hypertension. I don't mean by hemodynamically unstable shocked patients. I mean patients having severe hypertension. In these patients, we prescribe short-acting ACE inhibitor like captopril, and the maximum dose of captopril is 450 milligram per day. Captopril can be given every 8 hours, and we can reach up to 450 milligram per day, as I said. If there is intolerance to ACE inhibitor, we can give ARBs. And if the blood pressure is not controlled despite maximum tolerated dose of ACE inhibitor, we start to add on other antihypertensive classes like dihydropyridine, calcium channel blockers, diuretics. But if there is associated pulmonary edema, as diuretics may worsen renal functions in patients who is not overloaded. Also, alpha blocker can be used. Beta blockers, we don't prefer to use beta blockers, especially the non-cardioselective beta blocker, for fear of vasospasm as complication of beta blocker, which can worsen Raynaud's phenomenon. And I want you to know that scleroderma renal crisis is considered the Raynaud's phenomenon of the kidney in patients with systemic sclerosis. So beta blocker is the last choice of us, and if we prescribe beta blocker, we need a cardioselective beta blocker to avoid vasospasm as a complication from beta blocker. The second category of the patients is patients having severe hypertension more than 180 over 110 or severe symptoms. These patients will be triaged to the intensive care unit. In these patients, we need to reduce the mean arterial blood pressure by 10 to 20% in the first hour to reach a target diastolic blood pressure of about 100 or 110 millimeter mercury at maximum in 24 hours. We use intravenous antihypertensive agents like nicardipine or sometimes nitroglycerin, sodium nitroprusside, and after stabilization of blood pressure, we start to gradually introduce a low dose of ACE inhibitor. The target blood pressure, of course, for these patients is less than 130/80. I want to also to stress on a certain point. In scleroderma renal crisis, of course, there is rise in renal functions. If we prescribe ACE inhibitor can lead to rise in renal function. The evidence supports to use ACE inhibitor even if there is a progressive rise in renal function after use of ACE inhibitor, because simply the rise of renal function is mostly due to progression of the scleroderma renal crisis rather than side effect from ACE inhibitor. So don't stop or reduce the dose of ACE inhibitor in scleroderma renal crisis even if serum creatinine is rising. If there is severe symptoms, we will give symptomatic treatment like anti-epileptic for convulsions, intravenous vasodilators, or loop diuretics in pulmonary edema, tachyarrhythmia, and as we said, there is concern on beta blocker. If severe kidney failure is occurring and the dialysis indications apply, like hyperkalemia, pulmonary edema in anuric patients, severe acidosis, of course, these are indications for hemodialysis. In the presence of TMA, thrombotic microangiopathy. If thrombotic microangiopathy subsides after the control of severe hypertension, that's good. If it didn't subside, we can start a trial of plasma exchange. But there is limited evidence for the benefit of plasma exchange in these patients. So it is considered a second line of treatment after failure of ACE inhibitor to control the crisis and to subside TMA after control of hypertension. That led to the American Society for Apheresis, the ASFA, to give category 3 for plasma exchange in patients with scleroderma renal crisis. Another option for treatment is eculizumab. Eculizumab, of course, is a humanized monoclonal antibody targeting C5, the terminal component of the alternative pathway of the complement system. Eculizumab is FDA approved in the management of two diseases, paroxysmal nocturnal hemoglobinuria and atypical HOS. There is some case reports of a variable outcome of the use of eculizumab in scleroderma renal crisis after failure of the conventional treatment to control the crisis, that's to say ACE inhibitor. The outcome is variable and there is no strong recommendation to use eculizumab in this setting. And I would want here to stress on a certain point. All of us, of course, now know atypical HOS. In atypical HOS, sometimes there is a trigger that leads a genetically predisposed patient to develop uncontrolled activation of the complement system, leading to unmasking of atypical HOS. So if we are faced with a case of a scleroderma renal crisis that is presented with TMA and the TMA doesn't subside after control of the severe hypertension by ACE inhibitor, we can suspect that maybe there is unmasking of atypical HOS in genetically predisposed individual, and we can give a trial of eculizumab in this setting, and preferably to start genetic testing for atypical HOS. What about dialysis and the transplantation for patients with scleroderma renal crisis? As regards the prognosis, end-stage renal disease develop in about 50% of patients with scleroderma renal crisis, even when it is recognized and treated quickly. Renal transplantation or dialysis are options for patients developing end-stage renal disease. But here there is an important point. Patients developing end-stage renal disease sequelae to scleroderma renal crisis may recover from dialysis and discontinue dialysis reported up to 2 years after start of dialysis by continuing ACE inhibitor even on dialysis. So there is a debate to dialyze these patients early versus late. Late, we are waiting maybe for a probable recovery and the discontinuation from dialysis by the use of ACE inhibitor. But here we wanted to say that the percentage of patients who can recover from dialysis is very small, just 10%. So another argue is to start transplantation in early, as only a minority of patients will recover by ACE inhibitors. So this is an important debate as regards the decision of transplantation. The other issue is the use of corticosteroids and the use of calcineurin inhibitors, which are known to predispose for scleroderma renal crisis. So this gives us also a challenge in the transplantation management. The other point to consider is the incidence of recurrence of scleroderma renal crisis in transplant patients. The incidence is variable in the literature. It is stated from low down to 5% and high up to 20 or even 50%. So the incidence is very astonishingly variable of recurrence of scleroderma renal crisis following transplantation. But let's to say an important rule, the outcome of patients on transplantation after scleroderma renal crisis is generally much better than the outcome on dialysis. So transplantation is better than dialysis, but the outcome of transplanted patients is less than the outcome of non-scleroderma transplanted patients. Key message concerning scleroderma renal crisis. To summarize, risk factors are the diffuse form of the disease, early onset of disease within 4 to 5 years, the presence of anti-RNA polymerase type 3, corticosteroid use, rapidly progressive skin disease with characteristic tendon friction rub. Predictors of good outcome are severe hypertension. Why? Because severe hypertension means rapid diagnosis. All of us will rush into the diagnosis of scleroderma renal crisis. Absence, of course, of severe organ damage in the form of kidney damage on biopsy or heart failure by elevated probrain natriuretic peptide. Patient may recover up to 24 months even on dialysis by the use of ACE inhibitor, but we said that this is a minority of patients ranging about 10%. Renal transplantation is an option, but early versus late, the challenge of immune suppression post-transplantation, the outcome compared to non-scleroderma transplanted patients remains an area of debate. Prophylactic benefit of ACE inhibitor and ARB is unproven. There is no evidence to support the use of ACE inhibitor or ARBs to prevent the occurrence of scleroderma renal crisis. Rather, the evidence is strong for the management of scleroderma renal crisis. Lots of autoantibodies can be encountered, like ANCA and lupus serology. Second manifestation for kidney affection in systemic sclerosis is calcium oxalate nephropathy. Calcium oxalate nephropathy can be seen in these patients secondary to malabsorption of dietary fat. Malabsorption of dietary fat due to small intestine, stomach, and colon involvement by systemic sclerosis leads to lots of luminal fat in the intestine. This competes with oxalate for calcium, and the oxalate now reaches the colon where it is absorbable. After absorption from the colon, oxalate then is filtered by the kidney where it combines with calcium again and precipitate in the tubule and causes severe tubular injury. This is the same pathogenesis of oxalate nephropathy anyway. Oxalate nephropathy can sometimes be seen after bypass surgery. Bypass surgery for obesity, if there is a short bowel syndrome as a sequelae for this complication, it can lead to oxalate nephropathy. Also, it can be seen in patients with Crohn's disease, and the oxalate stones also is a complication. This is due to malabsorption of fat and the competition with oxalate for calcium in the intestine. Early recognition is important. Lines of treatment can include prescription of diet low in oxalate, enhancement of GIT properties by the use of prokinetic agents, use of antibiotics for small intestinal bacterial overgrowth, sometimes calcium and magnesium supplements in a trial to combine with oxalate to prevent its absorption from the colon. Third manifestation of scleroderma is hypertension. Hypertension can be estimated to occur in about 12 to 43% of patients with systemic sclerosis, and it can lead to the development of chronic kidney disease. However, let's to say that the exact relationship between the kidney and the hypertension is not known. Hypertension may be cause for kidney disease, and hypertension may be sequelae to chronic kidney disease. The onset of hypertension typically occurs after a period of about 4 to 7 years after initial diagnosis. The proposed etiology for hypertension is maybe diffuse obliterative vasculopathy. Some confounders include the use of corticosteroids or calcineurin inhibitors in some patients. Hypertension can be isolated, or it can be also complications seen in patients developing scleroderma renal crisis or patients developing ANCA-associated vasculitis. Another scleroderma renal manifestation is proteinuria. Proteinuria affects about 1/3 of patients with systemic sclerosis, and of course, proteinuria and specifically albuminuria is a marker of generalized endothelial dysfunction, which carries a high risk of cardiovascular morbidity and mortality. Patients having predominant albuminuria were found to have a long duration of disease and a high likelihood of systolic hypertension, while patients having intermediate molecular weight proteinuria like IgG they were more likely to have diffuse form of the disease and severe GIT manifestations. Proteinuria more than 1 gram is of course an indication of kidney biopsy. However, its occurrence is uncommon in patients with systemic sclerosis. Another kidney-related manifestation is isolated decline in glomerular filtration rate. A longitudinal Canadian study in more than 400 patients with systemic sclerosis followed for 2 years discovered a decline in GFR, characteristically more common in patients having comorbidities like diabetes, hypertension, and myocardial involvement. However, this decline is not so progressive in the majority of patients. This decline is more prevalent in the limited cutaneous form of the disease, as in the limited cutaneous form of the disease, pulmonary hypertension is much more encountered than in the diffuse cutaneous form. Pulmonary hypertension can lead to right-sided heart failure, elevation of central venous pressure, giving rise to high interstitial pressure in the kidney, and can lead to accelerated decline in glomerular filtration rate. CKD, of course, is considered one of the complications of systemic sclerosis, and it can occur without prior history of scleroderma renal crisis. In general, it carries a benign prognosis. The progression is not so rapid, and the causes may be pre-renal causes, like in cases of right-sided heart failure due to pulmonary hypertension, or drugs like excessive use of diuretics, non-steroidal anti-inflammatory drugs. All these can predispose to early development of CKD in these patients. Another kidney scleroderma-related manifestation is reduction in renal function reserve. What's renal function reserve in the start? Renal function reserve is a stimulated test. It tests the ability of the kidney to increase its basal GFR in response to stress in the form of protein load, whether oral protein load or intravenous infusion of amino acids. So it is a characteristic test to test the ability of the kidney to increase its basal GFR in response to stress in the form of oral protein load or in the form of intravenous infusion of amino acid. We can measure GFR by plasma clearance, for example, of a substance called iohexol. We give the protein load and measure the GFR after 1 hour if it is oral protein load, and after half hour if it is in the form of intravenous infusion. Renal function reserve can be used, for example, in the preparation of donors to test the function reserve of kidney function in potential donors. It can be used as a test to detect complete recovery from AKI. Of course, all of us know that AKI is a risk factor for CKD because repeated episodes of AKI lead to reduction in the renal function reserve. Sometimes we have apparent full recovery after AKI. You measure the renal function and you measure the GFR, everything is okay. The patient now is completely recovered from AKI. This is not the case in every case. Some cases are apparently full recovered. However, if you make renal function reserve, you can find that this patient having apparent full recovery and the renal function reserve is dropped. The normal range of the renal function reserve is about from 6 to 40%. It doesn't have an absolute figure, but of course, as long as it is high, you are assured that the patient is having a good kidney function. Can be also used as a test in patients undergoing cardiac surgery to predict the occurrence of AKI following cardiac surgery. So renal function reserve, I think it is a test that will be much used in the future. It can be used here in systemic sclerosis as an early detection of renal vasculopathy. We mean increase in renal vascular resistance due to obliterative vasculopathy complication from systemic sclerosis. In systemic sclerosis patients, these patients were discovered to have reduction in renal function reserve. Elevated renal vascular resistance can be also a manifestation of scleroderma. Elevated renal vascular resistance is considered the Raynaud phenomenon in the kidney. There is vasospasm in the kidney. It can be detected by Doppler ultrasound. However, it doesn't predict the future development of scleroderma renal crisis. It doesn't predict the future development of scleroderma renal crisis. And that's to say, there is no up till now recommendation, for example, to use prostacyclin in a trial to make vasodilatation for the kidney and prevent the development of scleroderma renal crisis. Limited evidence to support this maneuver of prostacyclin infusion to improve renal vascular resistance and prevent development of scleroderma renal crisis. Penicillamine nephrotoxicity. Penicillamine was one of the drugs which were used as a chelating agent and anti-fibrotic agents. It was used here in patients with systemic sclerosis in the previous era, but 20% of patients using this drug developed membranous nephropathy with nephrotic range proteinuria that characteristically improved with medication withdrawal in majority of patients, and only minority required steroids and immune suppression as well. Another important complication of scleroderma related manifestations that should be differentially diagnosed from scleroderma renal crisis is ANCA associated vasculitis. And there is an important comparison between scleroderma renal crisis and ANCA associated vasculitis. Scleroderma renal crisis occur more commonly in the diffuse form of the disease, while ANCA associated vasculitis occur more commonly in the localized form of the disease. Scleroderma renal crisis occur early after the disease onset, up to 4 to 5 years after diagnosis. However, ANCA-associated vasculitis were found to occur late after disease onset. Scleroderma renal crisis can be complicated by malignant hypertension, and the 10% of the patients are normotensive, as we mentioned, while in ANCA-associated vasculitis, hypertension is more likely to be mild. The characteristic antibody which could be present is anti-RNA polymerase 3 antibody in scleroderma renal crisis, while in ANCA-associated vasculitis, it is more likely to be B-ANCA rather than C-ANCA. The presentation is mainly acute renal failure with usually severe hypertension in scleroderma renal crisis, while the presentation of ANCA-associated vasculitis is somewhat subacute onset rather than acute onset, but this subacute onset can be progressive if there is presenting glomerulonephritis. Steroids may precipitate and increase scleroderma renal crisis, while ANCA-associated vasculitis characteristically respond to steroids, as we know. ACE inhibitor is the first line treatment in scleroderma renal crisis. However, ACE inhibitor, of course, is not a line of treatment in ANCA-associated vasculitis, but we prescribe cyclophosphamide or rituximab in addition to steroids. So this is a very important comparison between scleroderma renal crisis and ANCA-associated vasculitis. The last kidney manifestations which can be encountered in scleroderma patients is the antiphospholipid antibody syndrome related nephropathy. There is documented presence of antiphospholipid antibody in these patients. Antiphospholipid antibody, of course, differ from antiphospholipid syndrome. To diagnose antiphospholipid syndrome, you need a positive antibody and a positive clinical event in the form of thrombotic or obstetric event, and the antibodies characteristically should be positive in a period of twice in a period of 3 months. So there is difference between positive antiphospholipid antibodies and antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome, if present in the kidney, it can give rise to manifestations like TMA, renal artery thrombosis, or renal vein thrombosis. In the setting of scleroderma, there is limited research linking antiphospholipid antibodies to scleroderma. Thank you very much, and sorry for being late in this presentation, but lots of manifestations were found after reviewing the literature, which can be affecting the kidney related to scleroderma, and I needed to focus not only on scleroderma renal crisis, but on several manifestations related to scleroderma which can affect the kidney. Thank you very much.
Thank you. Thank you, Professor Hesham. A very interesting lecture and very comprehensive lecture, and it deserves all the time. And you are really not that prolonged, but you mentioned many manifestations for scleroderma in your lecture. I think the question you highlighted what's scleroderma in the start, what is scleroderma, general idea about scleroderma, pathogenesis, clinical manifestations, different forms of scleroderma. You are also highlighted manifestations, renal manifestations or kidney manifestations of scleroderma, including scleroderma renal crisis, which is the most famous, and other manifestations, including autoimmune disease such as ANCA-associated vasculitis, antiphospholipid CKD, isolated proteinuria, isolated hypertension, rapid progression, rapid GFR, isolated GFR progression, or even loss in a reserve. Thank you for this very comprehensive journey through scleroderma. And my question and my comment is that I think it will be the idea of many. You mentioned many manifestations. All these manifestations can occur with the scleroderma and can occur generally. I can expect the patient with hypertension, simple hypertension, to have a decline of GFR, to have subnephrotic proteinuria, to have. So, is the key is the presence of skin manifestations, typical skin manifestations to suspect is that related to scleroderma? Here comes the second question. What is against that the patient of scleroderma to have simple hypertension as anyone? ممكن يكون عنده عيان سكليروديرما وجاله ضغط عالي زيه زي غيره. يعني ايه المشكله؟ Comes here. Please let me give you the questions or that all are related، كلهم يعني مع بعض. ANCA associated or antiphospholipid associated is it some form of mixed connective tissue disease, can be secondary antiphospholipid due to lupus for example, not related to scleroderma per se. The last question اللي هو الدايليما المحيرة، ال TTP or thrombotic microangiopathic TMA is it related to hypertension? How can we discriminate? Is it related to hypertension effect or scleroderma effect? This is the important. So these manifestations are related to the scleroderma or associated manifestations due to some other disease. يعني ممكن العيان يكون عنده حاجه ثانيه في نفس الوقت، ممكن يكون الهايبرتنشن سيفير هايبرتنشن دي تو سي كي دي مثلا او اليفيشن. ازاي نقدر
هو طبعا البيشنت اللي هافينج سكليروديرما لازم انا ابقى حاطه تحت الفوكس بتاعي لو انا ملم او يعني اوير بكل الكومبليكيشنز اللي قدامي، فانا هستنى ان انا عيني على الكدني وهفوكس على كل المانيفستيشنز. بالنسبه للهايبرتنشن، الهايبرتنشن زي ما حضرتك قلت، طب ما الهايبرتنشن ممكن يبقى كومن مع الكوموربيديتيز، العيان ممكن عنده ميتابوليك ديسفانكشن، عنده دايابيتس
وارد؟ ما ده
وديسليبيديميا
السؤال.
وميتابوليك سيندروم. احنا كمان زي ما قلنا العلاقه الهايبرتنشن بالسكليروديرما is not clear. Hypertension may be cause for kidney dysfunction in this patient and may be result for kidney dysfunction. فبالتالي انا ما
تمام.
اقدرش احط ايدي بالظبط او احلف يعني بشكل دقيق هو بالظبط ريليتد للسكليروديرما ولا لا. وزي ما قلنا الهايبرتنشن مش يعني ممكن يكون ايزوليتد مانيفستيشن، ما عندهمش حاجه، انا مش شايف ان في اي افكشن في الكدني او اي حاجه، غير ان انا اقدر اقول ان الهايبرتنشن ده يمكن يكون سيكولي لديفيوز فاسكولوباسي، واللي هو في الغالب واخد الكدني في سكته كمان كرينال فاسكولوباسي. وكمان
خلينا نتفق ان السكين مانيفستيشنز ار نيسيسري.
السكين مانيفستيشنز هي طبعا الكدني هتبقى انفولفد اكتر في اللي هي السيستميك الديفيوز كوتينيوس سيستميك سكليروز. فالديفيوز كوتينيوس
الديفيوز
سيستميك الديفيوز دي هي اللي فيها لازم يكون السكين سيكنينج بروكسيمال للميتاكاربوفالينجيال جوينت، ان اديشن بقى للبروجريشن كمان بروكسيمال وديستال وفيس وترانك. هم دول اللي انا عيني عليهم اكتر ان هم يجي لهم الكومبليكيشنز كتير. اللي
هي
وان
المشكله هتبقى في الليميتد فورم، البروبلم ويل بي ان ذا ليميتد فورم.
رغم ان احنا برضو قلنا الليميتد فورم في حته، قلنا ان الليميتد فورم علشان عندهم بالمونري هايبرتنشن، ايزوليتد بالمونري هايبرتنشن اكتر، ممكن يكون عندهم some sort of functional renal impairment بسبب elevated central venous pressure. فممكن دايما الاقي عندهم الرينال فانكشنز عاليه بس احنا شايفين انها بري رينال زيه زي اي عيان رايت سايدد هارت فيلير، فده اللي ممكن نشوفه في الليميتد فورم اكتر. فدي بالنسبه للهايبرتنشن ما نقدرش نقول ان في اجابه واضحه اذا كان ده بالصدفه العين كان هيجي له هايبرتنشن، اذا كان ده سيكولي للسكليروديرما. نقدر نقول ان ما فيش اجابه واضحه والعلاقه مش واضحه قوي ما بين الهايبرتنشن وما بين السكليروديرما. طيب نمسك حاجه ثانيه، الميكسد كونكتيف تيشو ديسيز. هو الميكسد كونكتيف تيشو ديسيز هو الاوفرلاب سيندروم، هو ان العيان يكون عنده اتليست تو مانيفستيشنز diagnostic for two cholinergic disease، اثنين او اكتر، ده الاوفرلاب. اي اثنين بقى، بوليمايوسايتس، سيستميك لوبس، روماتويد ارثرايتس، سكليروديرما، كل ده تمام. لكن الميكسد كونكتيف تيشو ديسيز بالذات ليه تعريف. ميكسد كونكتيف تيشو ديسيز يكون عندي الانتي يوريدين رايبو نيوكلي بروتين، انتي يوريدين 1 رايبو نيوكلي بروتين بوزيتيف اوتو انتي بودي، ان اديشن ان انا عندي سكليروديرما وبوليمايوسايتس واللوبس. فده بالنسبه للميكسد كونكتيف تيشو. هنا ممكن الاقي تي تي بي، ممكن نلاقي تي تي بي، ما احنا عارفين برضو ان التي تي بي ريبورتد انه ممكن يتشاف في حالات اللوبس، وفي كيس ريبورتس ريبورتد ان في حالات تي تي بي معاها سيستميك سكليروسس. فبالتالي لو انا عايز اقول ان التي ام اي اللي عندي ده بسبب ايه، انا يمكن قلتها ضمنيا في النص. التي ام اي ممكن يكون بسبب السيفير هايبرتنشن اللي في السكليروديرما رينال كرايسيس. فالعرف يقول ان انا لما همانج الهايبرتنشن، لو الهايبرتنشن سبسايدد والتي ام اي كمان مانيفستيشنز، ابتديت الاقي بليتلت كاونت نورماليزيشن، ال دي اتش بيقل، الكلام ده، يبقى انا ماشي في السكه الصح، يبقى التي ام اي ده سيكوال للسيفير هايبرتنشن اللي معاهم. طب انا نزلت الهايبرتنشن والتي ام اي مش بيتصلح، التي ام اي مش بيتصلح رغم ان انا ابورتد الاتاك اوف السيفير هايبرتنشن. هنا لازم ادور في الرير، ادور في الرير دي بقى اللي هي ايه. طب والله الادم تي اس 13 اكتيفيتي اخبارها ايه؟ وكلنا عارفين ان الادم تي اس 13 اكتيفيتي دلوقتي بتتعمل في المعمل، وكمان في عندنا بلازميك سكور، فيري سيمبل سكور، ممكن يديني بروبابيلتي العيان ده عنده تي تي بي ولا لا من غير ما اعمل الادم تي اس 13. بلازميك سكور ده بيعتمد على بنحط البليتلت كاونت، اذا كان في هيستوري اوف اكتيف كانسر، اذا كان العيان المين كورباسكولار فوليوم بتاعه اخباره ايه، الكدني فانكشن سيرم كرياتين اخباره ايه. بنطلع سكور، لو السكور ده اكتر من 7 العيان ده لايكلي ان عنده سيفير تي تي بي. لو السكور ده من 4 ل 5 ده ماين، فده مبدئيا ممكن استبعد التي تي بي بالبلازميك سكور ده على ما تطلع الادم تي اس 13. ودايما عموما في حالات التي تي بي كلنا عارفين ان التي تي بي ما عندهاش بريديليكشن للكدني قد ما ليها بريديليكشن للسي ان اس. فكان دايما يتقال ان البليتلت كاونت لو اوفر 30,000 والرينال امبيرمنت از ماتش هاي، يعني الكرياتين اكتر من 1.8 والبليتلت كاونت فوق ال 30,000، this most probably excludes the TTP as a diagnosis of renal impairment. علشان التي تي بي تاثر على الكدني لازم الاقي العيان عنده سيفير تي تي بي والبليتلت كاونت فيري لو. فدي برضو حاجه كمان ممكن ناخدها انها تاكسكلود معانا التي تي بي من غير ما نعمل ادم تي اس 13 لو هو مش افيلبل. طب عملت اكسكلوجن للتي تي بي، طبعا الشيجا توكسين ايكولاي او اللي هي الاستيكيوس انديوزد اتش يو اس، دي طبعا بيتعمل بي سي ار للشيجا توكسين لليورين. وطبعا ده الاسم الادق، الناس زمان كانت تسميها دايريا اسوشيتد اتش يو اس، وهي الدايريا طبعا بروفد تو بي نون سبيسيفيك مانيفستيشن تتشاف في التي تي بي في الاتش يو اس في تي ام اي ريليتد لاي حاجه في الدنيا، فما عدناش بنسميها دايريا اسوشيتد، لا هي لازم اشوف التوكسين ده في الاستول. طب استبعدت دول، هبدا افكر في ايه؟ هبدا افكر ان قد تكون دي اتيبيكال اتش او اس، وهي دي سكه الاتيبيكال اتش او اس. الاتيبيكال اتش او اس ده عشان يتشخص عايز هاي اندكس اوف سسبشن، عيان انا اتعاملت معاه على الكوزز الواضحه اللي قدامي للتي ام اي والتي ام اي ما فكتش، نزلت للحاجات الريرر استبعدتها التي تي بي والاتش او اس ما لقيتها، التي تي بي اسف والستيكيوس ما لقيتهمش، ابدا افكر انها تكون اتيبيكال اتش يو اس. والجينيتك تيستنج هو طبعا هيدينا سترونج باور فور diagnosis but it is not essential for diagnosis. الجينيتك تيستنج ممكن بيجايد معايا مين هعمل له فيوتشر ترانسبلانتيشن مين لا، مين اكتر عيني عليه ان يجي له اكسترا رينال مانيفستيشن، لكن مش لازم استناه. ففي رايي الشخصي ان لو حاله سكليروديرما رينال كرايسيس وعندها سيفير هايبرتنشن وعندها تي ام اي، صلحت انا الهايبرتنشن والتي ام اي ما بتتحسنش، ممكن افكر انها تكون اتيبيكال اتش او اس. وطبعا ممكن قبل ما افكر اعمل الاتيبيكال انها تكون اتيبيكال اتش او اس ودي ايكيوليزوماب. الايفيدنس بيقول ان انا ممكن اعمل ترايل بلازما اكستشينج، لكن زي ما قلنا الكاتيجوري بتاعها في الامريكان سوسايتي فور افاريسز از جاست كاتيجوري 3، ما هياش واخده يعني انديكيشن قوي. فالحالات اللي هي عندها تي ام اي ومش بتفك دي ممكن نفكر في اتيبيكال اتش يو اس.
اوكي ثانك يو، شكرا دكتور هشام على التوضيح.
شكرا.
في سؤال question من الدكتور معتصم
تمام.
about ACE inhibitors. An ACE initiated for the treatment of scleroderma for renal crisis. Should it continue indefinitely and should it be used routinely after kidney transplantation?
هو الفكره هنا في نقطه بقى ايه. طبعا هو لو بدأناه المفروض ان احنا نكمل عليه. ده احنا قلنا ان ايفن العيانين اللي على دياليسيس لو سيكولي لاند ستيج رينال ديسيز فروم سكليروديرما رينال كرايسيس هيكمل عليه، وستيل بيبقى عندي هوب ان العيان ممكن يريكفر، لان في ريبورتس ان عيانين قعدوا سنتين على الدياليسيس وقدروا ان هم يحصل لهم ريكفري للرينال فانكشنز ويحصل لهم ديسكونتينيويشن من الدياليسيس بسبب استخدام الاس انهبيتور. ففي الغالب اللي هيجي له سكليروديرما رينال كرايسيس هكمل معاه، مش هوقف الدواء ده، وهتنيني ماشي عليه بطبعا ايه بقى التوليريتد دوز، يعني لانه وارد ان انا اعلى بالدوز جامد علشان ابورت الاتاك، لكن بعد كده همشي بالتوليرابل دوز اللي انا ايه انزل بيها محافظ على الضغط وفي نفس الوقت العيان محتملها. طب هل هي ليها ايفيدنس ان هي بقى ان العيان يكمل عليها بوست ترانسبلانتيشن عشان تبريفنت فيرذر ديفلوبمنت اوف سكليروديرما رينال كرايسيس؟ الحقيقه دي انا جاوبتها لا، ما فيش ايفيدنس يسبورت البروفيلاكتيك يوز اوف ايس انهبيتور عشان يبريفنت الكرايسيس. فانا هقول ان اللي جاله انا ماشي عليها، لكن اللي ما جالوش قبل كده مش هديها، مفيش ايفيدنس يسبورت ان انا اديها، والا كان طلع ريكومنديشن ان كل اللي عندهم سكليروديرما اديهم ايس انهبيتور عشان اريح دماغي وما يجي لهمش سكليروديرما رينال كرايسيس. فاللي جاله هكمل، اللي عمر ما جاله سكليروديرما رينال كرايسيس مش هقدر اديها كبروفيلاكتيك ميجر ان ما يجيلوش سكليروديرما رينال كرايسيس بس ترانسبلانتيشن.
يعني transplant patient with scleroderma not recommended to use ACE inhibitors كأنتي هايبرتنسيف، الهايبرتنشن والكونتينيو هايبرتنشن.
لا، ما لو هي سيكول للسكليروديرما رينال كرايسيس انا هكمل وحد التولرابل دوز، يعني ده الايفيدنس اللي تحت ايدينا، هو كان عنده سكليروديرما رينال كرايسيس انا هكمل على الاس انهبيتور ده انديفينتلي. لكن طبعا وارد اني هنزل بالدوز مش زي ما كنت بديها ديورنج الاتاك، فانا هنا عندي جاستيفيكيشن ان انا اكمل عليها بوست ترانسبلانتيشن. لكن لو عيان زرع لسبب اخر، ما احنا قلنا بتوع الكالسيوم اوكزاليت نفروباسي دور بور بروجنوزز ممكن يوصلوا لاند ستيج رينال ديسيز، ده ساعتها انا مش هقدر اديله اس انهبيتور علشان ما يجيلوش سكليروديرما رينال كرايسيس. يعني
ولو هايبرتنسيف هايبرتنسيف
اف هايبرتنسيف هنا ساعتها انا عندي انديكيشن، لو العيان هايبرتنسيف ممكن اديله، واحنا حتى عارفين ان بوست الترانسبلانتيشن في الايرلي بيريود بتاعت الاريثروسايتوزز احيانا كنا بنلجا لاستخدام الاس انهبيتور، يعني لو عندي انديكيشن تاني لاستخدام الاس انهبيتور هديه. لكن اللي اقصده ان انا بديها فقط بروفيلاكسس تو بريفنت سكليروديرما رينال كرايسيس مفيش ايفيدنس عليه،
لا ما
ملهاش
طيب.
ايفيدنس.
Okay. What about C5 inhibitors in treatment of scleroderma renal crisis?
بالنسبه للسي 5 انهبيتور في السكليروديرما رينال كرايسيس، هو انا اتكلمت فيها فعلا في اثناء المانجمنت.
دكتور عبد
الايكيوليزوماب زي
الله.
ما قلنا، زي ما قلنا هو اف دي اي ابروفد في حالتين بس، باروكسيزمال نوكتورنال هيموجلوبينوريا واتيبيكال اتش يو اس. لكن اللي اتعمل عليه في السكليروديرما رينال كرايسيس هي مجرد 3 كيس ريبورتس تقريبا كده، 3 كيس ريبورتس كانوا بيلجأوا له افتر فيلير اوف الايس انهبيتور والبلازما اكستشينج، يعني بياتي خط ثالث خالص، والاوت كام بتاعه كان فاريبل، في عيانين عادي حصل لهم ديس، وفي عيانين وصلوا اند ستيج رينال ديسيز، فبالتالي ما فيش ايفيدنس، ليميتد ايفيدنس عليه ان احنا نديله ريكومنديشن ان هو يستخدم في حالات السكليروديرما رينال كرايسيس. زي ما قلنا ممكن افكر فيه في حاله تي ام اي بقى وانا شاكك ان يكون وراها اتيبيكال اتش او اس وحصل لها ان ماسكينج بالسكليروديرما رينال كرايسيس، لكن هو تحديدا
يعني
لا، هو ياتي
suspected.
سسبكتد يعني، لكن ياتي هو ايه خط ثالث خالص خالص في ورا الاس انهبيتور وورا البلازما اكستشينج.
يعني if you suspect HUS يبقى احنا ممكن نستعمل
لو في سسبشن ده
الانزيمات
ممكن
الرئيسية.
يبقى الانديكيشن لو في سسبشن.
last question. انت want to transplant, you said early or late, no difference or cannot guarantee. والريكومنديشن ان احنا ممكن العيان recover after dialysis for at least 6 months or at least 1 year. recovery
تمام.
is possible. ايه رايك؟ انت قلت ان هو no clear recommendations في هذه النقطه، ولا الافضل ان احنا to delay dialysis to delay sorry transplantation؟
هو احنا هنحطها في صوره نقط. ايه النقط دي؟ ان الاوت كام بتاع السكليروديرما بيشنتس اون ترانسبلانتيشن از ماتش بيتر اون داياليسيس، ده رقم واحد. لكن الاوت كام بتاع السكليروديرما ترانسبلانتد بيشنتس كومبيرد تو نون سكليروديرما ترانسبلانتد بيشنتس از لور. يبقى داياليسيس ولا
يعني
ترانسبلانتيشن
scleroderma better on transplantation
مقارنه بالسكليروديرما اللي على داياليسيس،
لا
بالسكليروديرما
dialysis
اللي على داياليسيس، لكن السكليروديرما
generally.
جنرال ترانسبلانتيشن احسن من الدياليسيس. ولكن دي بقى الحته دي فيها ديبيت دي، ان زي ما قلنا في ناس بعد سنتين من الدياليسيس حصل له ريكفري ورجع، لكن البرسنتج بتاعهم قد ايه؟ 10%، يعني برضو الامل ضعيف. لذلك في ديبيت حاليا ان ما تستناش ازرع، وفي نفس الوقت في اللي بيبص للكيس ريبورتس دي بيقول هستنى. فاذا دي اريا اوف ديبيت، ازرع ولا ما ازرعش، اريا اوف ديبيت. احتمال العيان يرجع، لكن بنسبه قد ايه؟ زي ما نقول الريبورتد في الليتريتشر 10% هو اللي هيريكفر. والفكره في ان ليت يعني افتر الترانسبلانتيشن، قلنا ان الكورتيكوستيرويد طبعا واحد من الموست فيمس بريسبيتيتنج فاكتور للسكليروديرما رينال كرايسيس، وكذلك السي ان اي. فده برضه بيخلي عندنا تشالنج في التريتمنت بوست ترانسبلانتيشن. بالتالي انا لو على رايي الشخصي انا هستنى. يعني انا لو على رايي الشخصي انا، يعني لو انا اللي بختار، انا احدي للعيان فرصه واشوف على دياليسيس العيان ده هيعمل ايه. يعني ده هيكون الافضل، خصوصا ان انا عارف ان في تشالنج في التريتمنت بوست ترانسبلانتيشن. لكن ستيل الاريا دي، زي الحته دي زي ما قلناها، اريا اوف ديبيت. ازرع بدري ولا ازرع متاخر، ستيل اريا اوف ديبيت، وكل راي ليه وجهه.
راي البيشنت كمان مهم.
وراي البيشنت كمان، هو توفر طبعا الفاينانشال ستيتس
دونر.
والدونر بالظبط. والكوموربيديتيز، يعني برضو خلي بال حضرتك، لو حد كان جاله هارت فيلير من السكليروديرما اساسا، يعني برضو الاذر كوموربيديتيز اللي مع العيان ايه، كلها حاجات need to be individualized مع كل بيشنت لوحده.
You received many thanks for your lecture. دكتور سارة إبراهيم، دكتورة سارة، دكتورة مروة رمضان، دكتور أحمد سالم، الدكتور محمود الشيخ، منورنا طبعا. شكرا دكتور محمود على مجهودك معانا. كل دول بيشكروك دكتور هشام على المحاضرة الجميلة.
ده انا طبعا اللي بشكرهم ان هم استحملوني. ومحاضره مش شرط يعني ان كل الناس تبقى حباها، لانها مش بتتشاف كتير. وانا سعيد ان حضرتك كلفتني بيها. يعني للامانه انا استفدت، قعدت ذاكرتها عشان احضرها. ويعني انا بشكر حضرتك جدا على الفرصه دي يعني، وبشكر كل الناس اللي حضرت ويعني ادت من وقتها وقعدت معانا. وشكرا جزيلا لحضراتكم جميعا.
احنا اللي بنشكرك شكرا جزيلا على المحاضرة الجميلة دي. قلنا نختتم هذه الحلقة. كلوز. ان شاء الله نشوف حضراتكم الاربع الجاي. شكرا دكتور هشام على المحاضرة الجميلة.
شكرا جزيلا
شكرا
لحضرتك. شكرا
دكتور
استاذنا العزيز.
معتصم.
شكرا دكتور معتصم. شكرا جزيلا
على مجهودك معانا. شكرا لحضراتكم جميع الساده الحضور. ونتلاقى ان شاء الله الاربع الجاي في نفس الميعاد باذن الله 9 مساء. CME chapter is indeed CME chapter lectures and meetings. Thank you. شكرا. تصبحوا على خير والسلام عليكم ورحمه الله وبركاته.
وعليكم السلام ورحمه الله. شكرا.